Hello students, welcome to the discussion of the MCQs in the subject of Pediatrics for the Foreign Medical Graduate Examination. I am your Pediatrics faculty, Dr. Ashutosh Agarwal. So we start with the first question. In which of the following condition in neonate treatment is required? Treatment is required. Subconjunctival hemorrhage can very well be seen in the neonate, and this usually requires no treatment. So here particularly if you say there is no treatment which is required is caput succedaneum. The child was suspended in the vertex position. Due to gravity, the fluid came down and there is a subcutaneous swelling. There is a subcutaneous swelling. So this caput succedaneum, which is a subcutaneous swelling, this also does not require any treatment. Cephal hematoma. Child was particularly in the position and there was use of vacuum or forceps which resulted in the subperiosteal hemorrhage. Now in this case also usually no treatment is required, only you monitor the child for neonatal jaundice. But the classical onset hemorrhagic disease of newborn, that is seen between 2 to 7 days after birth. It is seen between 2 to 7 days after birth in a child which is delivered at home. In a child delivered at home and on exclusive breastfeeds. So the child was delivered at home. That means the child did not receive injection vitamin K. And the child is on exclusive breastfeeds. So most efficient vitamin in breast milk is vitamin K. So this child is indirectly having the vitamin K deficiency, and this requires to be treated by injection vitamin K. So out of the 4 choices being given, the treatment is particularly required in the classical onset hemorrhagic disease of the newborns. Going on to the next question. Out of the following which can be seen in the infant of diabetic mother in the neonate period? Now in the infant of diabetic mother, if you consider, there are 2 problems which take place. One is fetal hyperglycemia. This fetal hyperglycemia, this mainly causes defect in organogenesis. Right? So the anomalies which you can get is, for example, ventricular septal defect, you can get is transposition of great arteries, you get is sacraligenesis. All of them are due to fetal hyperglycemia. Another thing which is present here is fetal hyperinsulinemia. Fetal hyperinsulinemia. Now this fetal hyperinsulinemia, what does it causes? Insulin is the major hormone responsible for intrauterine growth. So more insulin means more growth. So this child is large for gestational age or macrosomia. Large for gestational age or macrosomia. In this child, insulin is more. In spite of getting the adequate diet, this child can have hypoglycemia. Right? Then there can be hypocalcemia, because insulin prevents PTH release. Then particularly insulin stimulates erythropoietin, and due to this there is polycythemia. So out of the choices which have been given in this question, the right answer is polycythemia can be particularly seen in the infant of diabetic mother. There is definitely hypertrophic cardiomyopathy, but this does not cause any harm to the child. Hypertrophic cardiomyopathy which can be seen. Moving on to the next question. Mother had fever along with skin rash in first trimester. Child born at birth has cataract, has failed this hearing test, presence of continuous murmur in the left infraclavicular area. These findings are suggestive of following intrauterine infection. So if you see here, the positive findings are the child is having the cataract. That is one thing. The child has failed hearing test. So this child might have sensory neural hearing loss. and there is presence of a continuous murmur in the left infraclavicular area, which is heard in the patent ductus arteriosus. Cataract, SNHL, PDA, all three are the features of the congenital rubella syndrome. Congenital rubella syndrome. So if you see the answer here, the answer goes in favor of rubella. If you see the findings in the toxoplasma, there is hydrocephalus, there is chorioretinitis, and there is intracranial calcification. So this is triad, something you get in the toxoplasma. So remember the triad of toxoplasma, remember the triad of rubella, and in the rubella the mother will always have fever along with the skin rash, and that was in the first trimester at the time of organogenesis. So child had the anomalies. Moving on to the next question. 4-year-old child has been treated for symptomatic urinary tract infection. Which of the following tests should be done to rule out any underlying condition? Now you should remember the radiological investigation. You should remember radiological investigation after first episode of UTI. First episode of UTI means the UTI which was symptomatic, which was treated. Now in the child there might be some underlying problem. So you need to rule out that. So which investigation needs to be done, that will depend upon the age of the child. If the child is particularly less than 1 year of age, so less than 1 year, you go for USG, you go for DMSA, this is dimercaptosuccinic acid scan, and you go for MCU, micturating cystourethrogram, that you go for this. 1 to 5 years of age, you go for 2 investigation, ultrasonography plus DMSA, and if any abnormal. Out of the 2, any abnormal, you go for MCU. More than 5 years of age, you go for ultrasonography, and if abnormal. If ultrasonography is abnormal, we go for the MCU plus DMSA. So this is something very important to be remembered. Less than 1 year, 3 investigation. 1 to 5 year, 2 investigations. More than 5 year, a single investigation. So now we look at the question again. The child has been symptomatic, age is 4 years. 2 investigations are indicated, that is ultrasonography plus dimercaptosuccinic acid scan. And if any one of this will be abnormal, we will be going for MCU, micturating cystourethrogram. Going on to the next question. A child has history of difficulty in walking. He was diagnosed as having upper respiratory tract infection 2 weeks back. 2 weeks back, there was an infection. Now the child is not able to walk. There is presence of purpuric rash on the gluteal region and lower limbs. Which of the following investigation should be done? Now child having upper respiratory infection, not able to walk, arthritis. If we only go this much, this can be rheumatic fever, one thing, and there will be particularly presence of a Henoch-Schönlein purpura. Both of them can have the same presentation. But there is presence of purpuric rash on the gluteal region and the lower limbs. This goes in favor of Henoch-Schönlein purpura. This goes in favor of the Henoch-Schönlein purpura. And in the HSP particularly, what is to be done? There is purpura which is present, and this purpura is mainly present on lower limbs. It is present on pressure point, that is the gluteal region, and if I am sitting like this, it is present on the extensor aspect of the upper limbs. In this case, there is risk of nephritis. There is a risk of nephritis, and the kidneys can be affected up to 6 months after the appearance of purpura. Kidneys can be affected up to 6 months after the appearance of purpura. So what it means is, in this condition, urine analysis has to be done for 6 months. In this condition, urine analysis has to be done for a period of 6 months. So this is a case of HSP. Why not rheumatic fever? Rheumatic fever, you get the skin rash, that is erythema marginatum, that is mostly present on the trunk and the proximal surfaces, and that has got a pale center. That is not a purpura kind of a thing, right? So this is most likely a case of HSP. Child is able to sit with support. Now sit with support, the age comes out at 5 months. Roll from prone to supine. Again the age is 5 months. Reaches out for objects, that is the bidextrous grasp. Bidextrous grasp, that again age is for 5 months, right? And the child rolling appears when which reflex disappears. The answer is asymmetrical tonic neck reflex, right? So rolling appears in a child. Rolling appears in child when asymmetrical tonic neck reflex disappears. Asymmetrical tonic neck reflex disappears. So if you see, we have given 3 milestones. All 3 are in the age of 5 months. Sits with support, rolling is present, reaches out for the objects, everything is 5 months. So our answer goes in favor of the 5 months. Answer goes in favor of the 5 months here. 3-year-old child has horizontal sulcus over the lower part of the chest and bowing of legs since 2 months. So 3-year child, there is bowing of legs, horizontal sulcus. This is signifying the Harrison sulcus. Harrison sulcus and bowing of legs. We are thinking of the picture of the rickets. We are thinking of the picture of the rickets to make diagnosis of nutritional rickets. Now nutritional rickets is something which is due to vitamin D deficiency. Vitamin D deficiency. And a line which you should always remember, normal PTH level. Normal PTH level excludes the diagnosis of vitamin D deficiency. Normal PTH level excludes the diagnosis of vitamin D deficiency. So if you are getting such a question, right? So for nutritional rickets, they are only asking, you should go for the PTH level. Alkaline phosphatase is increased even in the hypophosphatemic rickets. Urine phosphorus levels are decreased in hypophosphatemic rickets also, right? And they can be decreased in the chronic renal failure also. So therefore that does not make a diagnosis. To make the diagnosis of nutritional rickets, out of the choices given, always remember it is the PTH level, and normal PTH level, they excludes the diagnosis of the vitamin D deficiency. So if you get a question of rickets and you are being given normal PTH level, it is not vitamin D deficiency. Next one, a 7-year-old child has history of recurrent cough associated with wheezing in night. Wheezing in night approximately once in a month. Peak expiratory flow is 84%. Diagnosis of intermittent asthma is made. So in the intermittent asthma, one thing you should remember is the peak expiratory flow rate is more than 80%, and here it is given is 84%. So that is okay. So this is intermittent asthma, and in the asthma what you usually get is there is wheezing in night. So that is also given, wheezing in night here. So this is peak expiratory flow rate more than 80%, wheezing in night. You have made a diagnosis of intermittent asthma. And in the intermittent asthma, previously you were only giving short acting beta agonist alone. But now we don't give them alone. So we are giving is short acting beta agonist plus inhaled corticosteroids intermittently during attacks. Right? So the now protocol says even in the intermittent asthma, you need to give is the inhaled corticosteroids, not daily but intermittently. When the word comes persistent asthma, maybe mild, moderate, severe, you are giving daily inhaled corticosteroids. But here you are not giving daily, you are giving is intermittently. Next question. 2-year-old boy developed preference for using left hand at 8 months of age. Child started sitting at the age of 10 months, but the child should start sitting at the age of 5 months and without support at 7 months, so delay in milestones. Walking at 18 months of age, normally the walking develops by 15 months of age. So in this child there is one thing, that is delayed milestones, that is one thing, and secondly there is early handedness. There is early handedness. Normally the handedness is established by 3 years of age. In this child, the child is preference of using the left hand. Child limps with right foot while walking. So that means there is some problem in the right side. That's why he's using only the left hand. He's limping on the right foot. So this all findings are suggestive of the cerebral palsy, spastic hemiplegic type. In this spastic hemiplegic type, one finding which you should always remember is early handedness. Second, in this child, what you will get is asymmetrical morose reflex at birth. You will get is the asymmetrical morose reflex at birth. So two things are here. One is spastic hemiplegic type. So we are saying is asymmetrical morose reflex at birth, and second, there is presence of the early handedness. There is presence of the early handedness. Simple question, you can easily remember this. Now here we say a 9-month-old child has come with history of not able to sit yet, right? So that means there is a delayed developmental milestone. There is hypotonia, one thing, flat occiput, that is there, upstanding palpebral fissure. So the palpebral fissure has become like this, upward slant or upstanding, and plus hypotonia plus flat occiput. All these findings can be seen in a child of Down syndrome. In a Down syndrome child, there is delay in the milestone, that is one thing. There is hypotonia, that is the second thing. There is flat occiput which is there. There is upstanding palpebral fissure which you call as the Mongolian slant. Which you call as the Mongolian slant, right? So out of the choices being given, what I should go for is the chromosome karyotype. Chromosome karyotype. In thyroid function test, you can, particularly hypothyroidism, can have hypotonia, but you cannot explain the other features which are being given. Is clear? And apart from this, why MRI, that is not such importance, because hypotonia, flat occiput are straightforward with upstanding. The first diagnosis should be Down syndrome. So our answer here is the chromosome karyotyping to rule out the Down syndrome. All of the following skin lesions can be seen in tuberous sclerosis except ash leaf macules. This is the hypopigmented patches which are seen in tuberous sclerosis, and they should be 3 or more than 3. The shag green patch, this is something we say is the orange peel like consistency, just like the orange peel. So this is the orange peel like consistency, and they are most commonly seen in the lumbosacral region. Orange peel like consistency seen in the lumbosacral region. Periungual fibromas, they are 2 or more than 2 in number around the nail beds, and they are also called as the Conant's tumor. And all these 3 features, the BCD, can be seen in tuberous sclerosis. Out of the neurocutaneous syndrome, café-ola macules are seen in the neurofibromatosis 1. They are seen in the neurofibromatosis 1. Rest all the features particularly can be seen in the tuberous sclerosis. Next one. 5-year-old boy has difficulty in learning in classroom. Height and weight are on the 30th percentile and is having large head on the 96th percentile. There is macrocephaly. Child face is long, large ears, most likely genetic diagnosis is. Right? Now you can say a 5-year-old boy which are having this feature, a large face, large ears. So out of the choices being given, this basically fits in the category of the Fragile X syndrome. In the Fragile X syndrome, there is trinucleotide repeat mutation. It's a trinucleotide repeat mutation, and there is CGG repeats. So it's a trinucleotide repeat mutation, and there is particularly CGG repeats. The characteristic feature here is macroorchidism, enlargement of testes. Apart from this, there is a large face. There is particularly a large face, and this large face is due to large ears and large mandible. This is due to large face and the large mandible is there. Clear? So therefore, this is basically one of the features here. So we are going in the favor of Fragile X syndrome. Moving on to the question number 13. In all of the following congenital heart disease, pulmonary circulation is ductal dependent except. The question means is that the pulmonary artery is getting the blood through ductus arteriosus. That is the meaning of the word pulmonary circulation is ductal dependent. If there is severe abstinence anomaly, yes, because right ventricle size become less and it is pumping very less blood to the pulmonary artery. Pulmonary atresia, absence of pulmonary valve. If there is absence of pulmonary valve, intact ventricular septum is there, how will particularly pulmonary valve is absent? How will the pulmonary artery get the blood? It has to come from ductus arteriosus. Tetralogy of Fallot with pulmonary atresia. Again, absence of pulmonary valve. How will the pulmonary artery get the blood? So in all of these conditions, particularly in all of these conditions, pulmonary circulation is ductal dependent. In coarctation, if you particularly see the coarctation, let us suppose this is the heart here, and we are saying this is the aorta like this, and here we are saying is the pulmonary artery, and here this is the ductus arteriosus green color. If the coarctation is very narrow, very severe enough, so this lower portion of aorta is getting the blood like this. It is getting the blood like this. So what we mean to say, aorta is getting the blood through ductus arteriosus. So in coarctation of aorta, what word we make is systemic circulation. Systemic circulation is ductal dependent, right? Rest in all the condition, it is the pulmonary circulation which is ductal dependent, but here we say a coarctation, systemic circulation is ductal dependent. Going on to the next question. On 4th day after birth on routine examination, the child is having small white, there should be white spots on the nose and cheeks. The child is accepting, feeds well, and was born by the normal delivery, most likely diagnosis is, right? Now neonatal varicella will not present just with the white spots, right? If it has to be there, there should be hemorrhagic skin rash, and that to be particularly vesicles will be there, right? So skin, eye, mucous membrane by herpes, again vesicles, both are ruled out. This white spots most likely is the milia, which is present on the face. It is a normal finding, nothing to be done. If milia is present on the gums, that is called as the Bowen's nodules, and if it is present on the palate, it is called as the Epstein's pulse. Epstein's pulse, right? Rhizma toxicum is somewhat yellowish white. You can say yellowish white, they are there. It does not affect the palms and the soles. But this is not just like the white spots there, right? So this white spot on the nose and the cheeks is a very common finding seen in the newborn, and this is most likely the finding of milia is there. The last question here we say 1-year-old child has history of diarrhea and vomiting for 3 days. He is passing 6 to 7 times loose stools in 24 hours. Child is restless, drinking water regularly, that means child is thirsty, extremities are warm, that means no shock, nothing, best management. If you see your child is restless and thirsty, that goes into the category of some dehydration. And in some dehydration, you basically follow the plan B according to IMNCI. And the plan B says what? Oral dehydration solution, and you are giving usually ORS at the rate of 75 ml per kg for a period of 4 hours. So that is something to be done in this child. So if you get a question of dehydration, first classify the child into which category of dehydration, and then you think of the management. In minimal or no, it is plan A. In some, plan B. In severe, plan C. Right? So these were the questions of the pediatrics. I hope you liked the question. All the very best for your exam. Thanks.